Go ahead, Alan.
Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for today's Policy Spotlight discussion. Policy Spotlight is a series of virtual events Health Affairs launched last year, featuring in-depth conversations with influential health policy experts. Previous Policy Spotlights have featured CMS Administrator Chiquita Brooks-LaSure, CMS Innovation Center Director Liz Fowler, and most recently, the HRSA Administrator, the Health Resources and Services Administration, Carol Johnson. If you missed these or any of our other events, they are recorded and can be viewed on our website. If you're watching us live, you can submit a question using the Q&A box in Zoom. Earlier and shorter questions are more likely to make their way into the conversation. I'll do my best to bring them in as possible. Today, I'm joined by Dr. Nakela Cook, Executive Director of the Patient-Centered Outcomes Research Institute, or Pcori. Pcori is an independent nonprofit organization authorized by Congress in 2010 to improve the quality and relevance of evidence available to help patients, caregivers, clinicians, employers, insurers, and policymakers make better informed health decisions. It's the largest public research funder focused on comparative effectiveness research. It's funded hundreds of studies that compare healthcare options to help us learn what works best given patients, circumstances, and preferences. Pcori was funded in 2010 as part of the Affordable Care Act and reauthorized in 2019, so it's starting its second decade. We're going to cover a lot of ground, although we certainly can't cover all of what Pcori does, but I'm looking forward to diving into some of the priorities and the direction that the director is taking it. And so with that, it's really my pleasure to introduce my guest, Dr. Nakela Cook, Executive Director of Pcori. Dr. Cook is a cardiologist, a health services researcher. Before joining Pcori, she was Senior Scientific Officer and Chief of Staff at the National Heart, Lung, and Blood Institute of the National Institutes of Health. She spearheaded initiatives in precision medicine, data science, sickle cell disease, and women's health, always with a focus on stakeholder engagement. Dr. Cook, it's so nice to have you with me today on our Policy Spotlight.
Thank you so much for having me. I'm excited to be here and look forward to the discussion.
Yeah, I do too. And I have had the pleasure of speaking with you before today's event. I always like to make sure that you have the opportunity after my introduction to describe Pcori in your own words. I use sort of what's on the website, but tell us in your mind, what is Pcori? Why does it exist? Why does it need to exist?
Well, you certainly did capture some of the key elements, but I'm excited to talk about Pcori. And as you mentioned, at Pcori, we have a mission to generate evidence that creates a better informed health care system. And we do this by funding comparative clinical effectiveness research. And that research, as many of you know, looks at different approaches to healthcare delivery that will see what works best for different individuals in different circumstances. And in many ways, what we do at Pcori is really research done differently because we do this work by engaging all stakeholders in the healthcare community to help us to inform better evidence because we believe that actually will help with outcomes as well as a better overall health system and also improve efficiency and even make healthcare more affordable. And, you know, as a physician, I just know how challenging healthcare options can be for a patient. And in today's day and age, there are even more and more options available. And it's important for patients to feel that they have the information they need and their clinicians have the information that they need to make these important choices about their care decisions. And that's what Pcori is all about. When we talk about research done differently, we talk about engagement because we engage the stakeholders of the healthcare community, from patients being an area of focus even from Pcori's earliest phases, all the way to thinking about clinicians, policymakers, payers, and others that are involved in healthcare, to helping inform not just the questions that we focus on in our funded research portfolio, but also the actual conduct of the research. And so we're excited about those opportunities that Pcori has in its future, and the fact that we have a lot of results that are coming to fruition now and are primed for a focus on dissemination and implementation as well. Another component of how Pcori does research done differently. We try to get those results all the way across the finish line so that it can be useful and meaningful to those that really need it.
Now, if you were to land on Earth from another planet and find out that we have a huge research enterprise in health and medicine, you'd kind of assume it was about the patient.
Mhm.
So what is different about patient-centered outcomes research? You've described two dimensions. One is sort of the patient as outcome, but the other is patient as the one who's engaged in the process. How is that different from healthcare and health services research not done differently, done the same old way?
Well, certainly one of the key areas of focus at Pcori is engagement. And by engagement, we mean having patients and other individuals that are part of the healthcare system as partners in what we do, not just patients as potentially the participants in a research study, but actually individuals that help us talk about what's important for that patient to make the right decision for their healthcare or have better information for the decisions that they're facing in healthcare. We also find that having patients help us with teeing up questions, helping with identifying the research that we fund, and even participating in the conduct of the research makes it much more relevant, as well as tees up the opportunities for implementation. So engagement for us is not just about outreach. It's really about the integral nature of having patients and other stakeholders be part of the entire research continuum. We've supported that in many different ways and are starting to see the influence of what Pcori has done over the prior decade in terms of the reach of engagement and other even health funder arenas, et cetera, where the engagement of patients has not just participants, but as partners starts to make the work so much more informative and meaningful for all involved.
Yeah, so that makes me wonder. I mean, you have a large research portfolio, but it sounds like you're also trying to catalyze change that goes beyond what you fund yourself.
Mhm.
So do you feel like the country is in a different place with respect to uh, comparative effectiveness research or patient-centered research in general than it was a decade ago when Pcori began?
Indeed, and we're starting to see that influence of Pcori's existence in many other arenas. And I mentioned the fact that patient engagement itself has become more embedded in other primary research funders and institutions, including even in the discovery phases of research. We're now understanding that patient perspective has become, I think, much more front and center and top of mind for many research funders. We're also starting to see that the ideas around patient-centered outcomes research that really also thinks about the outcomes that are important to patients actually influence how a study is designed and conducted and what exactly is measured. And that information is starting to really permeate into other venues. We've also seen that organizations, such as academic organizations and others that are setting up research enterprises, are starting to think about how they create the opportunity to engage with patients and surrounding communities in order to have a more effective research enterprise. And many of those things we think can be attributed to some of Pcori's influence in the world of patient-centered outcomes research, and have certainly heard of organizations that attest to that when they speak with us.
Do you have any formal data collection on that, or is it sort of anecdote? I can certainly imagine people are eager to tell you when it happens, but does anyone sort of keep track of how much of the research enterprise has some of the dimensions that you consider important at Pcori?
We certainly do collect the anecdotes and we hear them from time to time in engaging with others. But you know, one of the things that I may mention is that in our portfolio, one of the things that we see is that we hear from those that are actually conducting the work how Pcori's influence has really shaped the research study and made it different than what they would have anticipated it to be. And so, for example, there is a particular Pcori-funded study that looks at reducing medical errors in hospitals, for example. And the intervention that was really tried there was around bringing together patients' families with the clinicians, the nurses, the physicians, et cetera, that are rounding in the hospital, and improving that communication during morning rounds in order to really have that opportunity for patients and their caregivers to understand the course of treatment, the care, the next steps and outcomes. And we found that there was actually a reduction in medical errors when that level of communication was enhanced. But what was really interesting is that the engagement of both the physicians, the nurses, as well as the patients in that setting really set the stage for this to be an effective study that was designed in a way to really get outcomes that were important to both parties. And so I think that's just an example of the type of work and then the results being reported in ways that stimulate that engagement aspect, and recognizing that that engagement aspect set up a design that was effective is the kind of thing that kind of spurs that influence that we were talking about.
So it's great to have a combination of sort of broad data and anecdotes. That's how the world works. So as I mentioned at the outset, you have this very broad portfolio. I'm just going to walk through a few elements of it, ask you to talk a little bit about priorities and reflections, and we'll just sort of take them as they come. I want to start with Peacore Net. Pcori put about $100 million in, I believe, to get it launched. I'm not sure all of our listeners even know what it is. You may be familiar with some of the Pcori research, but not have been involved in Peacore Net. So maybe after a little description, you could talk about what role you think it's played in promoting the comparative effectiveness research and what your vision is for its future.
Well, Peacore Net is certainly one of the things that we're very proud of at Pcori. And, we just recognized there was such a critical need to conduct research at a faster pace as well as more efficiently. And Peacore Net was really designed to meet that need. It is an investment in research infrastructure that brings together health systems and the electronic health record data from those health systems to provide real world data that will help inform both clinical comparative effectiveness research, as well as have broader and more applicable results. And so that was what Peacore Net was really designed to do. It's a network of networks. And it not only brings the power of data to bear, but also the ability to reach back to an individual patient or participant in a research study through that large design. And one of the things that I think is exciting about Peacore Net is that we, in the early days of Pcori, really focused on the infrastructure building and some pilot tests and projects in order to really make sure that Peacore Net was fit for purpose and ready for the comparative effectiveness research studies of national and large scale. And now Peacore Net is there, and it's becoming that resource that is being utilized in order to generate real world evidence by harnessing that kind of health data from encounters that happen every day across the country and in different settings across the country. It's nationally representative in ways that help us with geographic diversity, as well as tailoring to different settings and allowing us to bring large numbers of individuals together in studies to examine effects that may be different by population, by risk factor, things of that nature. And one of the exciting things really, I think that has come through in terms of the leveraging of Peacore Net relates to studies of questions that were out there for lots of people, such as a study that examined weight loss strategies and particularly looked at different types of bariatric surgery, including things like gastric bypass and gastric sleeves, to understand what worked best for different patients in different settings and different circumstances, as well as understand the need for even more procedures or hospitalization thereafter. And that type of information has provided individuals the real world evidence to be able to talk with their clinicians about some of the outcomes that would be of interest to them and have the information available to be able to choose the path that they think is most important. We've also had some really interesting studies that have leveraged and harnessed the power of Peacore Net in terms of using electronic health record data to randomize participants for studies and to be able to answer questions with that data in ways that are much more efficient. And that's been exciting to see come to fruition because those kinds of studies needed a proof of concept, needed the opportunity for us to try doing things differently with large data aggregation and things of that nature. And PCORNet's been able to show us that that's truly possible. So maybe I'll start there with just that little tease and happy to answer some further questions.
Sure. So I'm thinking we published a piece recently, and it's certainly not the only one's report that when it comes to clinical trials, there's still a lot of concern. Of course, you were at NIH about equitable representation of different populations in our clinical trials in various genetic databases. We've published on that topic as well. How comfortable are we that the network of networks in PCORNet don't just replicate those problems, or how do we address it if they exist?
It's a wonderful question. And in fact, one of the things that I mentioned about PCORNet has really broad reach. And we've tried in many ways as we have created the infrastructure to use for more pragmatic and large scale trials that are national in scope to represent the diversity of the nation in that catchment of clinical systems that are represented there. And PCORNet is both large health systems as well as smaller systems that are geographically dispersed across the nation and also represent the same types of race and ethnicity breakdown that we see nationwide in this country. We recently went through an effort with our Board of Governors to think about the priorities for PCORNet as we move forward in our next phase at Pcori. And one of the key things we began to talk about is that utilizing this rich research for national scale studies that are representative of the country would be a critical way to move forward, especially given what we have in this rich resource that is unlike anything that really exists for these types of studies in the country.
Is there a PCORNet 2.0 that you have in mind, or is it just doing everything it needs to and you need to keep keep it up and running?
Well, I think one of the key things I will just mention is that the PCORNet infrastructure went through an amazing building phase in order to really get to where we are. And what we see now is the next opportunity for PCORNet is to be able to continue to have these larger scale studies, as well as some of the smaller ones that reach rare populations that may be very distributed across the country because of the reach that such a network allows. And so having that opportunity is something we're certainly interested in. We've also recognized that PCORNet, with both these larger health systems as well as smaller community health systems and even federally qualified health centers as part of PCORNet, has a richness about it in terms of reaching populations that we may not always be able to reach in clinical studies. And so that's the other phase that we're entering in, is how do we do that within a large network for studies of this type. And I lastly will mention that as we've moved into a phase of data where electronic health records are certainly one aspect of large data and big data that's out there. Big data is being harnessed for health all over the country, and particularly thinking about social determinants of health and other types of data sets that may be helpful in understanding influences on health. That's another area that PCORNet is right to move into in its next phase, to think about how we bring these types of data sets together in order to really understand a fuller picture of health, one that is health that really represents where a patient or an individual lives, works, learns, and plays. And so that's really where I think the next opportunities are.
I have more questions, but I want to bring one in that came in from the audience. It's fairly specific, but I think it may be of interest to others. Someone noted the funding levels of the Peacore Trust Fund growing over time, and are interested in what is the basis of the size of the Peacore Trust Fund.
So the Peacore Trust Fund has certainly been, I think, important for us as There are several priorities that it brings to bear in terms of thinking about the importance of that patient-centered outcomes research, the dissemination and implementation components of that. And what we've seen build over time is a foundation for comparative clinical effectiveness research, some studies that are coming to fruition and real opportunities going forward. And so that growth in the fund also allows us to be able to pursue not just the active comparative clinical effectiveness research, but also moving that research that has completed into that dissemination, implementation, and widespread that is really important. The other interesting piece around the Peacore Trust Fund is that it is a trust fund that we also share with our other federal agencies and colleagues. And so we work closely with our colleagues at the Agency for Healthcare Research and Quality, as well as at HHS, because we have some shared goals in moving forward the mission of the trust fund. And so it's an exciting time to be able to do that, building on a foundation that's been established for many years.
Can you just say a little more about how it is funded?
Yes. So the trust fund itself is funded via two main streams, one that's a mandated appropriation from Congress, and the other that comes from a tax on payers, and particularly those large payers based on number of lives insured that contribute to the trust fund. And so payers are also an important component of thinking about comparative effectiveness research, because it is often information and evidence that we can generate that will help policymakers and payers as well in terms of making the choices that are going to be important for their constituents.
Thank you. Let me move to another topic. There's a broad priority within the federal government around prioritizing health equity. It's long overdue, but at least it is here, and everyone I talk to who's in positions that are tied to federal priorities is eager to discuss how that plays out. I'm struck here that Pcori, of course, was created before the most recent few years when the spotlight has shone much more brightly on issues of equity. I want to be very clear, many people been concerned about equity a lot longer than that. However, at the time of Pcori's creation, I think it's fair to say that in the public agenda, equity did not have the same profile it has now. So as you come into this role, I wonder if you could talk a little bit about how Pcori has had to change, how you think about its changing to reflect that priority in a way that maybe didn't have the same profile a decade ago.
I think it's a phenomenally important topic to talk about health equity. It's definitely front and center for us at Pcori. And, you know, when Pcori was established, early in its establishment, the Board of Governors set forth national priorities for research. And one of those priorities related to addressing disparities. And that was probably the way in which early Pcori thought about the importance of issues related to differences in health and outcomes, et cetera. And, you know, we have recently started to undertake a strategic planning process for our future, and our strategic plan is forthcoming. We're excited that it'll be coming to our Board of Governors in June. And one of the things we did as part of that strategic planning process was garner the inputs of a lot of stakeholders in our broader community to understand what was on their mind, what's important, what does the health and healthcare landscape look like, and how can Pcori contribute to making a difference. And we heard front and center that health equity was an important component for Pcori to take on. And in many ways, we've always thought that patient-centered CER is uniquely tailored to address health equity, because it really speaks to an individual, their specific circumstances, and the situations that they live in, and how that affects their health. And so by taking that as our cue and signal, I think what we've seen for the future at Pcori is that health equity has to be front and center. We have to double down on our efforts, and that it's part of our national priorities for health for the future, not just as one of the priorities moving forward, but one that's actually embedded in all of the other 4 national priorities for health at Pcori. And this means a lot to me because personally, I came to Pcori with a history that was very passionate about the fact that there are broad-based disparities in this country, and that, even growing up in the Southeast and the stroke belt, I witnessed these disparities before I really knew what they were called or how to describe them. But I knew that there was something there that I was ready to commit my career to. And coming to Pcori has given me an opportunity to see that furthered through the efforts that we certainly have doubled down on. And we've all witnessed in the pandemic, as well as just this window of opportunity that you've described, that these deep-rooted disparities are going to require us getting to the root of some of the issues, and that it means that we have to partner and collaborate differently in order to really deal with the issues that are not just happening in the clinical setting, but the types of interactions and influences on health that are happening outside of the clinic need to inform the research that we're doing to get down to really addressing the root causes to move forward an equity agenda. So that's what we're excited about at Pcori. We see this as a natural extension and next phase of a lot of the groundwork that was happening over the prior 10 years, and moving from addressing disparities to a national priority that's just simply stated achieve health equity is what we're excited about in this next phase.
I want to follow up a little on this. This is a great topic, and your comment toward the end about maybe even changing some of the questions or the context in which questions are asked, I'd like to follow a little more. As I heard your answer, sort of I think as the editor of a journal, I've seen the evolution in just the language people use. More historically, we were documenting disparities. We were trying to understand them. Now it's more goal-based, achieving equity, and I heard that loud and clear from you. But at the outset of your answer, you talked about sort of focusing on the patient. That's what Pcori does. That wouldn't necessarily bring with it an equitable outcome, I wouldn't think. So I guess along the lines of the last part of what you said, are the questions or hypotheses that people are bringing to be funded through Pcori changing? Are the data sources and data elements, as you discussed in terms of social context, changing? Are you looking differently, and your whole team and process looking differently at what mechanisms are being studied? I guess I'm just trying to go a little deeper in how it actually changes the day-to-day work at Pcori.
Certainly. I may start by mentioning that, even in the early days of a national priority around addressing disparities, we were intervention focused at Pcori, and recognizing that many descriptions of disparities already existed, that our opportunity was really around testing interventions and comparing interventions in order to understand what works in different circumstances. We've also had at Pcori a very kind of intense focus on certain populations that have had disparate outcomes. And some of that stems even from our authorizing law. And other of it is really related to where the opportunities lie for us to provide the type of information that's going to be important for people to make the right healthcare decisions for themselves in specific settings and under specific circumstances. And so that's always been a focus. We've also had the fortune of being able to think about pragmatic studies, large data sets, and things of that nature that allow for us to get to the outcomes that may actually look different amongst different populations. And so heterogeneity of treatment effects and things of that nature, where we examined how effects may differ for certain populations and certain circumstances, have been part of what Pcori has been able to do. And what we're interested in doing in terms of that change that you're talking about and moving forward is that we now have that opportunity to think about the additional data inputs, the types of information that may be an opportunity for multi-component interventions and things of that nature, that not just look at that clinical interaction, but also starts to think about the interactions that happen external to the clinic that influence health. And this may mean, an intervention that is going to also address potentially the circumstances of housing or education, et cetera, that may influence a health scenario or health outcome, and how we might be able to do that more holistically, where we're starting to think about a learning health system, which is centered around an individual and their unique circumstances and where they live, work, learn, and play, that may be different from thinking about a learning healthcare system that's really focused around an institution or an organization. And so that requires different data, that requires different thinking, it requires different approaches in the studies. And that's the opportunity that I think when we want to push toward an achievement of health equity that we have to seize.
That's very exciting. I'm also quite excited by what you said a moment ago about heterogeneity of results and effects. I do think, again, as the editor of a journal, that it is fairly commonplace to report average effects, that people are looking at interventions and they want to understand whether or not they move an outcome one direction or another. And heterogeneity is often sort of noise, and it affects explanatory power or confidence intervals, but it also could be actual heterogeneity that if we don't capture that, we could be doing a real disservice when it comes to equity goals. That's quite exciting to hear about that.
Absolutely.
And I'd love, given that you are a big part of what you do at Pcori is sort of help on the method side. I think helping move the methods forward in that as well as the focus could be very exciting. So you have sort of priority goals, but you also have some substantive priority areas. And I noticed when I looked at your annual report, mental health and behavioral health is the largest funding category. And I'll just say someone, again, coming in from the outside might not have expected that. So I wonder if you could say a little bit more about, again, the unique dimensions of patient-centered outcomes research when it comes to mental health and behavioral health. Why do we need Peacore, particularly in this area? Why is it such a high priority for Peacore?
I'm happy to. And, you know, I think in the midst of a COVID-19 pandemic that really has contributed to what I think is a growing and a devastating crisis as it relates to mental health, this is a really important discussion topic to have. And we've seen that, you know, in the pandemic, there's just been a host of factors, whether it be related to illness or loss or emotional distress or isolation, a job uncertainty that have come to the fore. And one of the things that we've also witnessed is that even before the pandemic, we understood that about 1 in 5 people in the United States in 2019 were living with mental illness. And so it's a major problem. And I think that's why we see it as a major investment in Pcori funded research. And one of the things I may even mention that we've specifically recognized is that we've also seen a rise in suicide rates, you know, increasing more than 30% since 2001. And so this predates the pandemic and is part of the remit that Pcori has to think about high burden illnesses that actually contribute to morbidity and mortality in the United States. And that's why you see mental and behavioral health as an important area of investment. And it also requires a tailoring of care, new approaches that are going to help us to identify at-risk individuals and how we tailor that in different settings and with different populations. And so it's perfect in terms of thinking about comparative effectiveness research and how we actually get to the issues that are going to be most effective for different individuals in different settings and unique circumstances. I'll mention that we've actually funded, as you highlighted, almost over $700 million in over 150 comparative clinical effectiveness research studies related to mental and behavioral health. And I'll give you an example of some of the types of things that make it kind of unique for CER. And one is that we've had the opportunity to think about health system and care delivery strategies as it relates to mental and behavioral health. And we've had a study that actually looked at expanded behavioral health homes and behavioral health home programs that were actually helping to treat individuals with severe mental illness. And these types of behavioral health homes were found to be effective enough to actually warrant the opportunity to move on to adoption in over 60 different provider organizations in many counties across Pennsylvania. And so identifying an opportunity like that that actually helps individuals with severe mental illness in a way that we hadn't previously organized care for those individuals before is why we think it's important to take these things on and then influence even the adoption of that type of care program more broadly in a statewide approach is a real, I think, proof point for the importance of this type of work.
As I listen to you and talking about changing delivery systems, I think, well, we have this thing called CMMI, the Center for Medicare and Medicaid Innovation, and they're funding a lot of experiments on changing delivery, and they're focused on high impact topics. How do you think about your portfolio relative to theirs? Do you coordinate? What kind of communication is there, alignment? Or do you see the goals, which they are, being different enough that maybe there's some overlap of topics, but we can really each just do our own thing?
We certainly do work with our colleagues at CMMI, at the Center for Medicaid and Medicare Innovations. And one of the things that we've found as a nice opportunity for exchange is that findings from comparative effectiveness research actually are often helpful for them to know about as they're kind of starting to shape demonstration projects and other types of things. So we're a little bit earlier on the spectrum than where CMMI is in terms of providing that evidence and information that then perhaps could move forward into demonstration projects. And that relationship of information exchange is an important part of, as I mentioned, that larger Peacore trust fund community that we think is important for us to really bring together in terms of moving the needle forward on many of these issues.
Are there, you mentioned the one example out of Pennsylvania. I certainly don't want you to, and you can't possibly have memorized all of the research you funded, just like I can't memorize every paper we've published here. But directionally, or in terms of certain categories of types of things, are there elements coming out of the mental health and behavioral health work? And maybe I'll just fold in, you also have a priority area around intellectual and developmental disabilities. So maybe sort of, again, this is a very broad net, but I'll throw to you a very broad question, which is, are there sort of more systemic lessons, not just specific models, but more systemic lessons that come out of this research portfolio from your perspective?
Well, I certainly think that there are lessons that we can leverage and utilize as we look at the issues of suicide, even amongst adolescents in the United States, as well as the opioid crisis that we're facing in the United States. And so our mental and behavioral health portfolio has certainly informed those other approaches in other arenas. And many of the same problems exist where we're seeing rising rates as well as the kind of challenges coming out of the pandemic in both of those areas. And we were fortunate to have had some inroads that we can now build upon in this kind of critical time. And I think that one of the key areas that we've recognized is that Pcori funded study work actually engages in a way that patients and caregivers and others are part of the dialogue and can not only help us shape the studies that are going to be ripe in these sensitive areas, but then also help us with the dissemination and implementation. And I'll give you one example where we've worked with veterans, particularly in terms of thinking about the pain management and reducing use of opioids in that setting. And we've found that actually the two groups of veterans being treated through Veterans Affairs have worked, one with a kind of pharmacist case manager type of setting, where another also works with kind of medical workers and mental health providers to meet some of their personal health goals. And what we're looking for is whether we can actually have an opportunity where opioid usage is reduced and less opioid medications needed, but other outcomes are actually improving. And that's the kind of work that actually may set up strategies that we can use in other settings related to mental and behavioral health. So as you talk about that, there's that kind of expansion of how a particular study may actually allow us to learn more in other settings. You also mentioned intellectual and developmental disabilities, and from our reauthorizing law, this was a research topic of priority for Pcori, and we've begun engaging very heavily with this community to understand what's important to them and how we can consider those critical care dilemmas in some of our comparative effectiveness research studies. And one of the things that came through very early on was that intersection of mental health in individuals with intellectual and developmental disabilities. And so we've been working to shape opportunities around research in this space at that intersection. So we're still so early in that we haven't learned enough to be able to report out on those findings, but we're excited that we've started to work with the community there and have seen that that's a high priority for them. So you hit it, kind of head on in terms of what we're seeing as a priority for opportunities at Pcori in that particular population.
I'll be very eager to see how that unfolds, and it's a very exciting area of growth. When you talk about what Pcori does, and we had that moment where we compared your work to CMMI, and I like the notion of sort of feeding into models. There is one big difference. CMMI focuses a lot on cost. And I remember when the debates were occurring around the creation of Pcori, and there was sort of a wall built that says you can't do cost effectiveness. This is not about selecting the most cost effective approach. You do comparative effectiveness. Can you talk to me a little bit about how you see that boundary? How do you make sure you stay on the right side of it? How do you understand the origins of that to make sure you're not just sort of following the letter of the law, but you get what the reasons are for those boundaries? And I'll be interested in how you think about that.
So one of the key ways that we think about issues around cost and value is an understanding of what's important to the healthcare stakeholder community that we work with. And, Pcori is focused on being patient-centered. And to be honest with you, cost is front and center on a lot of patients' minds. Out-of-pocket costs, loss of work days, absenteeism, presenteeism, those sorts of issues are really critical, as well as just, how much things cost in the healthcare system as they're pursuing care and opportunities. And in our reauthorizing law, we have a new statute that allows for the collection of the full range of outcomes data, which includes the collection of data on traditional healthcare costs, as well as those types of things that are really important to patients and others, including the things that I mentioned, like out-of-pocket costs, as well as presenteeism, absenteeism, things of that nature. So we really do need that full range of information on all the associated economic burdens in order to inform healthcare decision-making for patients, clinicians, and others. And so I think that's an important component of the way in which we think about things, but we're also taking a very deliberate and thoughtful approach to how we may consider in the inclusion of that type of data collection in our funded activities. And through that, we've engaged with a lot of our stakeholders, helped to identify a few principles that have been critical for the community in terms of making sure, first and foremost, we're dealing with health outcomes and the associated costs and economic burdens related to those health outcomes. We're also making sure that the entire health system can make better decisions. So by collecting data and providing it for policymakers and patients and clinicians, it allows them in order to see that information transparently. And we're definitely not trying to define what value means for every person in this country. In fact, we want to learn what value means for different individuals and stakeholder groups in the country and make sure that we can reflect that in the way in which we're collecting this type of information.
As I listen to you, it's a wonderful answer. I think back again to the concerns that sort of Pcori would become a NICE like they have in England in the UK, and that it was, really sort of deciding who could get what, and certainly no one wanted, or I should say no one wanted, but the statute reflected the desire not to have Pcori play a role like that. I do wonder if the modifications in the reauthorization in part are a reflection that cost has grown as an issue for patients, that it's really hard to talk about outcomes and what matters to patients if you don't talk about cost. And although, of course, this has been an issue for a long time for many people, it certainly is a growing one. So do you have a sense that maybe even the tolerance of around that topic is changing?
Well, I think one of the things that's important in our reauthorizing legislation to note is that it really centered around that collection of cost and economic burden data. And still, we do not support or fund analyses that would get to that level of cost effectiveness analyses or the reporting of qualities or things of that nature. And so it will definitely not put us in that category of looking as if we were other institutes or entities that do that type of work. But I do think that the concerns around rising costs, the burden that cost and economic the burden that patients and other healthcare stakeholders face is certainly front and center and is continuing to mount in this country. And so I think that is a real and one of the opportunities that Pcori could really be a trusted voice in this space because of the engagement we have with a broad stakeholder community and had become that trusted voice over time is partly, I believe, why we have this opportunity before us to be able to really hear those perspectives across the wide variety of stakeholders involved in healthcare and collect and generate that data that may be informative for the broad spectrum.
Well, as we come toward the end of our hour, I note that your predecessor, the first executive director, had about a decade-long tenure, and you're early in yours. If you can look out through into your crystal ball and think what you'd like Pcori to look like 5 to 10 years from now, and how you would know whether or not Pcori's been successful in the vision that you and, of course, the board and the authorizing statute have, not just your vision, but what are you hoping it will look like as you look into your crystal ball?
Well, I certainly hope that we at Pcori are generating that type of evidence that's really creating a better informed health system. And that we start to find that clinicians and caregivers and patients and payers look to Pcori routinely for the type of information that's going to help with those challenging clinical scenarios. I hope to see that Pcori has advanced the opportunities to leverage data in the setting of clinical questions and the opportunities that data has and big data has to really provide robust answers in very unique and tailored circumstances. And I'd love to see that type of integration between clinical care and research that really allows for an informed research platform and the dissemination and implementation of evidence in that clinical setting in an almost real-time way. That may be pretty far off, but I think that there's something in that vision that we can really contribute to. And the other thing that I recognize is that the types of clinical dilemmas that I face with my patients, that my family faces on a daily basis, and our friends and colleagues are facing, they're just becoming more and more important because we have more and more evidence that's coming out of discovery in a way that we need to understand what we do with that discovery information to make it relatable, meaningful and helpful in terms of, is that going to work for me or for my colleague or my friend? And that's what I want to see Pcori continuing to push the needle on. And I want Pcori to be that place of innovation in partnership with patients, with caregivers, with health systems, with payers, in ways that actually allow us to generate those unique outcomes that are really critical for parts of the population that haven't had that type of attention and focus when it comes down to health. And I think you can see a lot of that vision of what I hope to accomplish and see Pcori accomplish in those national priorities for health. They are broad, ambitious goals for Pcori, but I think that we have an opportunity for some real inroads in all of those areas. Achieve health equity as one that we really have an opportunity for inroads. the idea that we want an integrated learning health system that's centered around a patient, real opportunities proceed there. A research infrastructure that looks at a workforce and health data and systems that support comparative effectiveness research. And even that opportunity to build that communication science, dissemination science, and implementation science that helps bring the work across the finish line. And the opportunity for us to move earlier in the research ecosystem to be able to focus on new and emerging innovations in health and how they compare to existing ones. And those are the types of things that I think we really are poised to focus on in this next phase.
I appreciate the answer. And as you started to answer, I had this little tightening in my stomach, and it went like this. There are all sorts of private enterprises that are trying to do versions of what you describe as a business model. They're trying to get decisions, help clinicians and health systems make decisions, predictive modeling, care pathways for proprietary reasons, that they're trying to sell a product, and that's a great incentive to invest. But then it's an owned product. It's not something helping everyone as you described. How do you think about Pcori's role in achieving that really beautiful vision you set forth in an environment where there are also a lot of people trying to achieve something that looks quite similar, but wouldn't be so much necessarily in the public domain?
Well, probably two things. One is that Pcori is a publicly supported entity. And so everything we do is in the public domain and is in that sense, I think one of the reasons why we have the fortune of being a trusted voice and partner. And so we have that opportunity to really navigate that space and to think about what we can do in terms of bringing that type of independence and the way that we approach things toward, I think, a knowledge that many in the country are yearning for. I also wanted to emphasize the other piece here is that we are the nation's leading funder of comparative effectiveness research. And so that lens of taking that independent role and allowing that opportunity to compare what may be generated from many different sectors in order to really understand what works best in a certain situation for a given individual at a specific time is what I think makes the opportunity for Pcori a bit unique.
Well, as we come to a close, I always ask this question of all of my guests, and I'll tailor it slightly for you. Not every cardiologist dreams of becoming the executive director of Pcori. Your clinical training is obviously highly relevant, but it wouldn't have naturally led you to this place. So particularly for people a bit earlier in their career, thinking about the options before them and choices they might make, I wonder if you could offer any thoughts about your own career pathway, any advice or experiences you've had that you'd like to share.
I love that question because I'm always willing to share and hope that if my story can be inspiring to anyone, that it certainly would be worth my time and effort to do so. I did come to Pcori through a very unique path, and I think in many ways it built upon those experiences I had as a child growing up in the Southeast and the stroke belt, as I mentioned to you, and witnessing the disparities by not just race and ethnicity, but also geography, and trying to understand what that was all about. And, I knew I had a passion there, but I always wanted to go to medical school. And there was a point in the career where I had to make a decision about whether or not taking care of the individual in front of me was really going to deal with that public health situation I was looking at and the larger clinical issues I was seeing in our healthcare system. And I felt I had an opportunity that really was more like a calling to take on that path. And I eventually had strong mentors and supporters around me that really encouraged me to take on that path of thinking about public health and bringing that together with clinical medicine and with a research path. And ultimately, when I said, how am I going to knit this all in a career? I realized that there were organizations and entities that would help me facilitate that passion and goal in life. And I ended up at the NIH trying to bring that all together. And Pcori just felt like a natural next step in terms of being closer to the patients that I really cared about and was driven to do something about in the long run, and having that opportunity to bring some of my disparities related, outcomes research related kind of passions to play. And then the health policy components that I think really come into our day-to-day at Pcori just made it an exciting place to be. So it feels like a homecoming in some ways, bringing all those different pieces of myself together in a place where we have the opportunity to bring stakeholder perspectives and diverse perspectives across the healthcare enterprise onto the table, and really to get down to the issues that are most important to them, and to have the national platform like Pcori that's a leader in comparative effectiveness research to do that has just been a phenomenal path. And so if any are thinking about taking that research funding pathway, or even trying to get to that place where you feel you can give to more than one at a time, this has been an exciting path for me, and I certainly would encourage it for others.
I'm glad we took the time for me to ask and for you to answer that question. And I think the growth of trying to figure out what to do when you see that you want to affect more than the patient in front of you, not that it isn't critically important to serve the patient in front of you, but some are called to look at the context and other opportunities. And you described that in a very engaging way. And I'm sure it's inspiring some of those who are listening. So Dr. Cook, thank you so much for taking the time to talk with me. Great to learn more about Pcori and where you're headed and what your goals are and what you've accomplished. Really appreciate you being on today's Policy Spotlight. To those of you in the audience, if you liked the Policy Spotlight, visit healthfairs.org and sign up for other events. Join our email list and you'll get announcements as they arise. We do have another event coming up later this month that might be of interest to you on May 31st at 3 p.m. Eastern Time. Our authors, Rachel Hardiman and Bridget Davis, who were in our February thematic issue on racism and health, will be having a professional development event entitled Improving the Measurement of Structural Racism to Achieve Anti-Racist Health Policy, which is drawn from a paper they had in the issue on that very topic. Thank you again, Dr. Cook. Thank you to our audience for your attention, and we are adjourned.